everyone, I'm Dr. Purvi Kadakia Kutty, Consultant Paediatric Hematology and Oncology, Apollo Hospitals, Mumbai. Today, on the occasion of International Thalassemia Day, we are here to create awareness about what is thalassemia and a little bit about the burden of thalassemia in Indian children. Thalassemia is a genetic blood disorder which is inherited from both the parents to a child, and this confers an abnormal hemoglobin protein, as a result of which there is rapid destruction of the red blood cell, so there is hemolysis, and these children present with anemia. Thalassemia can be of two types, alpha thalassemia and beta thalassemia. This is based on which chain of the hemoglobin protein is defective. Both these disorders are monogenic disorders and they are inherited by autosomal recessive pattern. Now, based on the severity, thalassemia can be of three types: thalassemia minor, thalassemia intermediate, and thalassemia major. Thalassemia minor or thalassemia trait is a carrier state. It is not a disease. These patients have low hemoglobin, low red blood cell indices, and hence they are detected, but they do not have any symptoms and they remain to have a normal lifestyle. However, two thalassemia traits, when they marry and have a pregnancy, 25% there is a chance that the child will be a thalassemia major. Thalassemia major child presents with severe anemia between 1 to 2 years, or usually the first year of life, and he or she requires lifelong regular blood transfusions. Initially, they present with pallor or paleness of the skin, sallow complexion, poor appetite, delayed growth, and this leads them to a chronic transfusion program. After they grow, because of the chronic transfusions, they start to present with signs and symptoms of iron overload. So there is delayed growth, delayed puberty, defective bone formation which leads to easy fractures, and osteoporosis, endocrine problems like hypothyroidism, bony defects, hypopituitarism. They may also have delayed puberty. Then there are other complications which severe iron overload can cause by depositing iron on the liver and the heart. So these patients can also present with liver failure and cardiac complications. Thalassemia intermediate patients do not require lifelong transfusions. They may require intermittent or episodic transfusion therapy. Now, how do we detect a patient with thalassemia major? One is a complete blood count or a CBC, which will show low hemoglobin, low red blood cell indices, a peripheral smear examination, and a hemoglobin electrophoresis or HPLC, which will detect the abnormal hemoglobin. Also, we have DNA methods to find out the exact genetic mutation. So, genetic testing is also available to pinpoint the exact mutation of thalassemia. Now, what is the treatment of these children? These children ideally require treatment in a comprehensive thalassemia care center by a multidisciplinary team consisting of a pediatric hematologist, a pediatric endocrinologist, a specialized blood bank officer, nursing care, nutrition and diet care, and pediatric cardiologists. They require regular monitoring of complications of iron overload. They require safe blood transfusions which are given at regular intervals to keep their hemoglobin at a value above 9.5 to 10 pre-transfusion. After the first 15 to 20 transfusions, these children are put on oral iron chelation and they need to continue that lifelong to prevent side effects of severe iron overload. Also, these children require constant monitoring for their growth and their development and endocrinological complications. Since they are on chronic transfusions, they may also require monitoring of transfusion-transmitted infections. These children with regular transfusion and adequate iron chelation tend to have a near normal quality of life. However, The only curative treatment for a thalassemia major is a bone marrow transplant or a stem cell transplant, where the diseased bone forming cells or the abnormal blood forming cells are replaced by normal stem cells, which are obtained from a matched sibling, that is an HLA matched brother or sister of the patient. These procedures, when done in the right center, at the right time, and with the availability of a right donor, confers outcome of nearly 80 to 90%. So thalassemics can be cured by a bone marrow transplant. Lastly, I would like to appeal to everyone watching this video that please donate blood, as all the thalassemic children, the burden is quite large in India. Nearly 10,000 children are added to the pool every year. They require regular blood transfusions till they can undergo a bone marrow transplant. So, please go out and donate blood. Thank you.